Assistant Professor in the Department of Pathology Science. Today we'll be discussing about iron deficiency anemia. So anemia is defined as hemoglobin concentration in blood below the lower limit of the normal range for age and sex of the individual. So in an adult male, the lower extreme of the normal hemoglobin is taken as 13 grams per deciliter, whereas for a non-pregnant female, it's taken as 11.5 grams per deciliter. For a pregnant woman, it is 1 gram less than the normal for an adult non-pregnant female. Whereas in newborn infants, they have a higher hemoglobin level, and therefore 15 grams per deciliter is taken as the lower limit. Now, anemia can be classified based on the pathophysiologic mechanism and also based on their morphology. This morphological classification of anemia is the simplest way. Based on the morphology of the RBCs, which we see at the peripheral smear, it can be classified as microcytic or normocytic or macrocytic. Whereas based on the pathophysiology, anemia can be either due to increased blood loss, as in acute hemorrhage or chronic blood loss, or anemia can be due to impaired red cell production. This can be in the cytoplasmic maturation defect, or a nuclear maturation defect, or defect in stem cell proliferation and differentiation, or it can be anemia of chronic disorders, or a bone marrow infiltration, or congenital anemia. Next is anemia due to increased red cell destruction, which is also called hemolytic anemia. This can be either extrinsic or intrinsic. So the case which we are discussing today, which is iron deficiency anemia, is because of there is an impaired red cell production, and that too it's a cytoplasmic maturation defect, where there is deficient heme synthesis. This deficiency of iron is the most common nutritional disorder in the world. So if you see the prevalence of iron deficiency anemia, it is very common in developing countries like India. It's also seen in developed countries. It's seen among young children and also in pregnant women. That's mostly what's seen in developed countries, whereas it's very the prevalence is very high in developing countries. Now, this morphology of iron deficiency anemia is a microcytic hypotonic anemia, and iron deficiency, it interferes with normal hemoglobin synthesis and therefore leads to impaired erythropoiesis and anemia. Now, before we go into iron deficiency anemia as such, it's important to know the normal metabolism of iron. So the total body content of iron varies from 3 to 5 grams. Okay, so this 3 to 5 grams of iron is present in the body in two different forms. It's present as a storage pool and also a functional pool. So among the functional pool, majority of the iron is present as hemoglobin, which accounts for 1.5 to 3 grams. The remaining is present in the form of myoglobin and certain enzymes like caspase, cytochrome, and peroxidase. Whereas the storage form of iron is present as ferritin and hemosiderin, which accounts for around 1 gram of iron. So this iron is absorbed in the proximal intestine, which is the first part of the liver, and brush border cells. So this image is taken from Robbins, which depicts the absorption and transport of iron. So iron is available in two forms. One is heme iron and the non-heme iron. Heme iron, the major source is animal products. For non-heme iron, we get it in plant products. So 20% of heme iron is absorbed, whereas only a fraction, which is 1 to 2% of the non-heme iron is absorbed in the body. And this heme iron is transported by a channel called heme transporter, whereas non-heme iron, which is Fe3+, is converted initially to Fe2+. It is reduced to Fe2+ via an enzyme cytochrome B, which is present in the duodenal brush border cells. And then it enters the enterocyte via a channel divalent metal transporter. In the enterocyte, iron is either stored as mucosal ferritin, or it is further by a channel ferroportin. It enters the side, where it is converted by the enzyme hepastin or ceruloplasmin to Fe3+. It is oxidized to Fe3+, and this rapidly binds to plasma protein called transferrin, which delivers this iron to the erythroid cells in the marrow, which is then used for hemoglobin production. Okay. Now, an important thing here is the regulation of iron via this protein called hepcidin. This is a small peptide that is synthesized by the liver cells in response to increase in intrahepatic iron. Okay. So this hepcidin, what it does is it inhibits ion transfer from the enterocyte into the luminal side by inhibiting this channel ferroportin. It causes its endocytosis and degradation, and therefore it destroys this ferroportin channel. So as a result, as the hepcidin level rises, iron becomes trapped within the duodenal cells in the form of mucosal ferritin, which is then lost by shedding of the epithelial cells. Okay. So when there is iron stores in the body, there is high hepcidin levels, which inhibits absorption of iron. Whereas when the body iron stores are low, hepcidin synthesis falls, and this in turn facilitates iron absorption. So it not only reduces iron uptake from the enterocyte, but also suppresses iron release from the macrophages. That's another important thing. Okay. So this hepcidin, it also plays a central role in other diseases like anemia of chronic disease, hemochromatosis, which we will discuss later. And this transferrin receptor, which is present in the erythroid cell, okay, so this truncated portion of the receptor is shed into the blood, and it is measured as a serum transferrin receptor. This ferritin, it binds to this transferrin receptor, which is present in the erythrocyte cell. It takes the receptor via endocytosis. The transferrin enters the erythroid cell. Transferrin, the ion is utilized, whereas the receptor is recycled back, and it recycled back into the surface of the erythroid cell. And as the erythroid precursor matures into an intermediate normoblast to a late normoblast, that's when the transferrin receptor is released into the circulation, and that truncated portion of this transferrin receptor can be measured as serum transferrin receptor. Okay, so this is another chart taken from Robbins, which tells the iron metabolism. Okay, so iron absorbed from the gut into the plasma transferrin, it is taken into the liver, or it is taken into the marrow erythroid precursors, where it is utilized by the erythroid cells to form hemoglobin. Now these erythroid cells mature and they form circulating erythrocytes. The circulating erythrocytes, you know the lifespan of an RBC, it is around 120 days. So after 120 days, the RBCs are destroyed by the mononuclear phagocyte system. And here, the released heme is again taken up by the plasma transferrin, and it is recycled. Or this iron, the heme is shed by the keratinocytes or the gut epithelial cells, or by the endometrium. And this shedding and blood loss accounts for around 1 to 2 milligrams per day. Okay, so the amount of iron lost from the body is around 1 to 2 milligrams per day. So when you come to the pathogenesis of iron deficiency anemia, it is either due to increased blood loss, or there is increased requirement, or when there is inadequate dietary intake of iron, when there is decreased absorption. So this table shows the causes for increased blood loss. So one of the most important causes for increased blood loss in women is uterine causes like excessive menstruation, repeated miscarriages, postmenopausal uterine bleeding. Other causes are GI causes like peptic ulcer, hemorrhoids, hookworm infestation, cancer of stomach and large bowel, esophageal viruses, and other conditions like that. Renal causes can be due to hematuria or hemoglobinuria, or repeated epistaxis, or it can be due to hemoptysis. So increased requirement of iron is seen in growth in children, and it's seen in prematurity, it's seen in pregnancy and lactation. And inadequate dietary intake is especially seen when there is a poor economic status. Decreased absorption is seen when the patient has undergone partial or total gastrectomy, if he has a condition called achlorhydria, or when there is any intestinal malabsorption syndrome such as celiac disease. Okay, so there are few genetic forms of iron deficiency anemia. Just know the names of this. One is TMT1 deficiency. The other one is a gene mutation seen as TMPRSS6 gene mutation, atransferrinemia, and aceruloplasminemia. Now, another important thing is how does the patient present when he has anemia? Most important thing is they present with fatigue and weakness, Also dyspnea on exertion and palpitation. There will be pallor of the skin and mucosal membrane, which is seen in this case, in this image. You can see pallor. And also there will be menstrual disturbances in case if it's a woman, and also they can present with chronic GI bleed. Okay, another finding which is koilonychia, which is spoon-shaped nails. The nails are thin, brittle, and they can be functional ridges and flattening. So this condition is called koilonychia. This is seen in chronic cases where the patient has chronic iron deficiency. It's not an acute change, it's a chronic change. Other findings are atrophic glossitis, which is smooth red tongue. Another finding is angular stomatitis, where there is redness, soreness, and cracking of the angle of the lid. Okay, another important or rather weird clinical finding which you can see in patients with iron deficiency anemia is called pica, where the patient will have a craving to eat dirt, clay, mud, or anything like chalk, stuff like that. And it's seen, especially seen in children and also in pregnant women. And also patients with iron deficiency anemia are prone to have a lower immunity, and they are prone to have repeated infections because of low immunity. And then in children, they also present with irritability, decreased learning ability, and altered motor function. In extreme cases, can present with peritoneal hemorrhage. Now, there's a syndrome called Plummer-Vinson syndrome, which has a triad of features like esophageal webs, microcytic hypochromic anemia, and atrophic glossitis. So these three triad together is called Plummer-Vinson syndrome. Now, these patients will present with, and in addition to anemia, they can present with dysphagia. This dysphagia is because of the esophageal webs. So how do you diagnose such cases of iron deficiency anemia? It's mainly based on clinical evaluation, the history of the patient with the finding. In addition to that, peripheral blood smear findings, the iron status, and in last resort, bone marrow morphology and iron stores. So if you see the lab findings, hemoglobin is low. Again, the grading of hemoglobin is mild, moderate, severe, and very severe. So mild if it's less than 10 gram per deciliter, moderate is hemoglobin less than in the range of 7 to 10, and severe is hemoglobin 4 to 7, and very severe is hemoglobin less than 4 gram per deciliter. And if you see the MCV, MCH, and the MCHC, all these values are below the normal limit, whereas the RDW, which is the red cell distribution width, will be high. Okay, so this is a peripheral smear. This is an image of a normal peripheral smear, where if you see the RBC size is compared to the nucleus of a small lymphocyte, mature small lymphocyte, and it is almost the same in case of a normal RBC, and the central pallor will be less than 1/3. So this is a normal smear, whereas if you see iron deficiency anemia, the RBCs are smaller. So you can see in this image, this is a nucleus of a mature lymphocyte, and this is an RBC. It is smaller than the nucleus of a mature lymphocyte, and also the central pallor is more than 1/3. So that's one finding to call it microcytic hypochromic. Other findings are there will be, other than the RBCs being microcytic hypochromic, there will be anisocytosis. So anisocytosis is varying size of RBCs, and folliculocytosis is varying shapes. So ovelocytes, elliptical cells, pencil-shaped cells are all different shapes of RBCs. You can see in this image, this one is a elliptocyte where both the ends are blunt. A pencil-shaped cell, one end will be blunt and the other end will be pointed. Ovelocyte will be oval in shape, and there are so many different shapes which you can see in the iron deficiency anemia. Polychromatic cells are the previous stage of a mature RBC. Now, in iron deficiency anemia, sometimes the patient can present with coexisting folate or vitamin B12 deficiency. In such cases, you will see a dimorphic picture, because in B12 deficiency, the RBCs are large. So there will be megaloblast in addition to megaloblastic anemia. In addition to deficiency anemia, you will see a dimorphic population. This is another image that shows elliptocytes. All these are arrows are pointing towards elliptocytes, and here you can make out the central pallor being more than 1/3. So these are microcytic hypochromic RBCs, which are seen in iron deficiency. So microcytic hypochromic anemia is not only seen in iron deficiency anemia, it can be seen in other conditions also, especially thalassemia. But this is one. If you see WBCs and platelets, they will be normal. Another finding you can see in iron deficiency anemia is the presence of decreased reticulocyte count. Now, what are these reticulocytes? These reticulocytes are juvenile red cells released from the bone marrow into the bloodstream and contain remnants of ribonucleic acid and ribosomes, but they don't have nucleus. So this is a special stain called supravital stain, which you can make out these small blue dots. These blue dots are the ribosomes, ribonucleic acid, which has taken up the stain, and these demonstrate polychromatophores. Okay, so they will be reduced in iron deficiency. The other biochemical findings are a low serum iron level, total iron binding capacity will be high, low storage iron, which is serum ferritin. Other findings are red cell protoporphyrin, which is very low, and other findings are serum transferrin receptor protein will be raised. Now, the last resort is to do a bone marrow examination, which is normally not done to diagnose iron deficiency. But in a bone marrow, you will see the marrow cellularity will be increased due to erythroid hyperplasia. The erythropoiesis, if you have a closer look, they will be a normoblastic to micronormoblastic maturation. Myeloid, lymphoid, and the megakaryocyte cells will be either normal, will have a normal morphology. Now, another finding to demonstrate the storage iron in the marrow is to do a pulse stain, a Prussian blue reaction. It's also called pulse stain or an iron staining. Now, in this stain, this is a bone marrow showing pulse stain, all the iron particles have taken up this blue staining. So this demonstrates a good storage iron, whereas in iron deficiency anemia, the marrow will not show iron stores. So it will be nil or of a lower grade. So this is another image just to show the difference between a normal and an iron deficiency anemia, the morphology. A normal cell will have less than 1/3 central pallor, and the nucleus, the cell size will be similar to the nucleus of a small lymphocyte, whereas iron deficiency they have microcytic cells, and the central pallor will be more than 1/3. If you see the red cell indices in a normal patient, the MCV, MCH, MCHC will all be normal, whereas they are all reduced in iron deficiency. And the marrow erythrocytes will be normoblastic in normal cases, whereas it will be micronormoblastic in iron deficiency state. And the iron stores are significantly reduced in iron deficiency. This is another table that shows the range for a normal versus a value in iron deficiency. So this is a thing that's repeated. I've already mentioned on this. And the screening test for diagnosing anemia according to WHO is to do a hematocrit estimation and a hemoglobin. In addition to that, you do a serum ferritin and transferrin saturation. Confirmatory test is to see the response to iron therapy and repeat a serum ferritin, erythrocyte protoporphyrin, transferrin saturation, and serum transferrin receptor levels. Now, IRIDA, which is iron resistant iron deficiency anemia. It is a condition that is caused due to mutation in TMPRSH6 gene. Now, this gene product is involved in the suppression of hepcidin synthesis. So, in this disorder, suppression of hepcidin synthesis is lost and hepcidin level is high. So, therefore, it's called iron resistant iron deficiency anemia. So, this is another table that shows differences in different conditions like iron deficiency, chronic disorders, thalassemia, and sideroblastic anemia. So it shows the test and the different values. You can go through this chart. Now, this is an approach to microcytic hypochromic anemia. So when you see a peripheral smear with microcytic hypochromic blood picture, if the patient has, in addition to anemia, the patient has pancytopenia, you test the PNH. Now, if there's only microcytic hypochromic anemia, you have to do a serum ferritin level assessment. And if the serum ferritin is reduced, or if the red cell count is less than 5 million, you have to do a bone marrow iron stain to see for bone marrow iron stores. If it is nil, you know that it is iron deficiency anemia. If the serum ferritin level is normal or increased, and the bone marrow iron is normal or increased, you have further test. You have to see the fetal hemoglobin and check for hemoglobin electrophoresis. And if they are normal, that means it is anemia of chronic disease. Whereas if the electrophoresis shows something abnormal, where there is a hemoglobin A2 is increased or there's another abnormal hemoglobin, then you'll have to think of other possibilities like thalassemia and other hemoglobinopathies, including alpha thalassemia and thalassemia trait. Okay. So now if the serum ferritin is increased and the bone marrow iron stores are also increased, like there are ring sideroblasts seen in the erythroid precursor cells, then give a diagnosis of sideroblastic anemia. So what is the treatment of iron deficiency anemia? Main treatment is oral iron therapy. You only go for parenteral iron therapy if the patient is not responding to oral iron therapy or if he is intolerant to oral iron therapy. So this response to therapy is assessed by the reticulocyte count, 7th to 10th day of starting the treatment. Okay, so reticulocyte count, it will increase to 5 to 15%, and hemoglobin is restored in around 6 to 8 weeks. So this iron therapy should be continued for 3 to 6 months after hemoglobin has returned to normal to replenish the iron stores. If you do a bone marrow at that point, it will come back to normoblastic maturation. Now, parenteral iron therapy is given in cases, as I already mentioned, for patients who are unable to take oral preparations, who are intolerant to oral iron therapy. In addition to that, you can give it to cases in late stages of pregnancy, also in post-operative cases, patients with rapid blood loss, gastrointestinal disorders that affect absorption. The last resort is blood transfusion. Okay, so that's about the iron deficiency anemia, clinical features and management.